Thank you for joining us for today's webinar, Substance Use in Healthcare, Two Nurses Share Their Recovery Journeys. My name is Marla Kaufman, and I'm the Communication and Health Promotion Coordinator at IRETA. I'll be moderating our webinar today. I would like to go over some quick housekeeping items about how to use the WebEx technology and how to access continuing education credits before we get started. First, we would like to encourage you all to participate in today's webinar through two methods. If you have questions for our presenters or are experiencing any technical issues, please use either the chat function or the Q&A panel to communicate your questions. Our presenters, Jennifer Ritchey and Rachel Shuster, will pause throughout the webinar to answer questions. Feel free to submit your questions through the chat or Q&A box at any time. This webinar is approved for 1.5 PCB and/or NADAC credits, which are free. A certificate of attendance will also be available to download from your My IRETA account after the webinar. Please take note that it will take up to 48 hours for your CEUs and certificate to be available in your My IRETA profile because we have to cross-check your attendance with WebEx following the webinar. After the webinar, you will receive several follow-up emails. The first will be an email with a link to the evaluation. The second will have information on how to access your certificate of attendance and continuing education credits through your My IRETA account. We may send you an additional email to remind you of the evaluation. I would now like to introduce today's presenters, Jennifer Ritchey and Rachel Shuster. Jennifer Ritchey, RN, CARN, has been a registered nurse since 1996, beginning her career in ortho-trauma before discovering her passion for addiction nursing. She has worked in various roles in the SUD field, training from staff nurse to nurse educator and trainer to her current position as a clinical care manager. She is a certified addictions registered nurse, a member of the International Nursing Society on Addictions, and the Pennsylvania Medical Reserve Corps. Rachel Schuster, BSN, RN, CARN, and CAAP, is a certified addictions registered nurse and a certified allied addiction professional. After earning her Bachelor of Science in Nursing from Waynesburg University in 2012, she began her nursing career as a critical care nurse and taught nursing part-time as a clinical instructor before she transitioned to her current specialty of addictions nursing. Rachel has worked in a variety of settings, including as the charge nurse of an outpatient office-based addiction treatment clinic and as the site nurse of a residential treatment program for young adults. She now works as an addiction treatment specialist for Highmark Whole Care. Rachel is a person in long-term recovery from substance use disorder and enjoys speaking publicly about her experience and journey as a healthcare professional in recovery. She was selected as an honorable mention for Pittsburgh Magazine's 2019 Excellence in Nursing Awards due to her work in the field and in her community as an addictions nurse and advocate, and was awarded a 2021 Pittsburgh Recovery Award as a recovery pathway supporter. Rachel is a member of various professional organizations, including the International Nursing Society on Addictions, and has previously served on the board of directors as the 2019 to 2021 secretary. Her interests include substance use, addiction, recovery, stigma and discrimination, harm reduction, opioid use disorder, pharmacotherapy, naloxone, toxicology, health professionals in recovery, and chronic viral hepatitis C treatment. Okay, Jennifer and Rachel, if you are ready, I will now hand things over to you.
Great, thank you. All right, so I believe that I will be kicking it off here with some definitions and terminology. Inadvertently, Jen and I can throw around a lot of acronyms and letters, and as part of our journeys, there's a few things we just wanted to create a foundation before we get into a lot of this other information. So there's two different organizations that we will be talking about today. One is the PHMP, or the Professional Health Monitoring Program, This is a Pennsylvania organization that provides a method by which professionals that are suffering from a mental or physical disorder, including substance use disorders, might be directed to in order to help individuals find appropriate treatment and receive monitoring so that they can safely practice their licensed profession. Also in Pennsylvania, we have the Pennsylvania Nurse Peer Assistance Program, or PNAP. This was established in 2009, and they are a monitoring and advocacy program. So these go hand in hand for nurses in Pennsylvania. Any individual that is enrolled in the PHMP must also be enrolled in PNAP. However, nurses can be enrolled in PNAP without being looped into the PHMP. Within the PHMP itself, there are two different programs. First that we're going to talk about is the Voluntary Recovery Program, or VRP. This is administered by the Professional Health Monitoring Program, or PHMP, as per requirement by the Nurse Practice Act in Pennsylvania, and also other practice acts, because other licensees, not just nurses, can be in the PHMP. The objective is protection of the public. As you can see with the list of the participating boards here, there are a handful of different license types that can be in the PHMP's Voluntary Recovery Program. In order to be eligible for this program, the individual must voluntarily consent to a 3 or more year agreement. And in turn, the disciplinary action is often deferred, meaning so long as the licensee adheres to recommendations and stipulations of the contract, there is no license suspension or revocation. And the licensee remains anonymous, meaning there's no public record of participation. And to the nursing board, they are just a number in this program. Throughout the contract and upon completion, they stay anonymous. There are a few things, however, that would make someone ineligible for these kind of programs. Most notable is if an individual is convicted or pleads guilty or no contest to a felony or a misdemeanor under the Controlled Substance, Drug, Device, and Cosmetic Act. A few other things include diversion of controlled substances for sale or distribution, a history of practice that involves significant patient harm or sexual boundary violations, and failure to successfully complete a similar program in another jurisdiction. Alternatively, there is the disciplinary monitoring unit. This is very much the same with a few key differences. Like the VRP, it's administered by the PHMP, Nurse Practice Acts. The objective is protection of the public. It was established in June of 1994 for licensees with formal disciplinary action by licensing boards. And those key differences are that the individual can be required to enroll in this. Now, the voluntary program, it can come across as voluntary, but oftentimes it is not so much voluntary. It's just, hey, we're offering you this voluntary program. You can stay anonymous. Like, what are your thoughts? You can enroll in this. And oftentimes, if an individual does not respond to that voluntary contract offering, it can go into a disciplinary state, which would require enrollment if the individual wants to keep their license to practice. This does include license suspension or revocation in a lot of cases, but not always. And the stipulations are very comparable, with the caveat that the licensee's involvement in this program includes public record during participation and once they successfully complete. Worth noting, there's an overrepresentation of nurses in these programs, and I really like to note this because although the ratio of nurses to physicians in the United States is 3-to-1, there's a 5 to 6 times greater representation of nurses in these programs compared to physicians. And although I don't have a straightforward, this is exactly why this is occurring, often I could make an educated guess that this is likely due to access, perhaps. Nurses are often passing a lot of controlled medications, controlled substances. Oftentimes, nurses are kind of the hub in the hub and spoke model of healthcare. If we're thinking about it in a direct care kind of way, the nurse is really managing that holistic care and working with a lot of different professionals. And so I think through those different touch points, there's oftentimes a lot of individuals who might be able to recognize an issue and report that if necessary. And oftentimes, I think that, we just, like I said, there's that access. Looking at the top 15 license types that are listed in order of representation within these programs, worth noting as well that these are just the public records. So this doesn't include things like the BRP that would likely change some of these statistics, but are still very representative of probably the overall population. Nurses are right at the top, RNs, LPNs, vocational nurses, but that is followed by physicians, pharmacy and pharmacy techs, and multiple other different license types.
So there are several requirements for both PNAP and the PHMP. The first of which is completing any treatment recommendations. The nurse or the licensee will typically have to have a drug and alcohol assessment, and from there then a determination or recommendation is made for what level of care or what level of treatment they should begin. So after that level of treatment, whatever it may be, an inpatient stay, just an outpatient rehabilitation stay, the next requirement would be immediately after the treatment would be what's called a 90 and 90. So 90 meetings in 90 days, 90 12-step meetings traditionally, like an Alcoholics Anonymous, NA, Narcotics Anonymous. And that needs to start immediately after inpatient or, immediately upon beginning. Requirement is for total abstinence. Long-term MOUD is not allowed except for naltrexone. That is the only uh, pharma, you know, pharmaco form of MAT that is allowed in this program. There are many work restrictions that go along with that, ranging from the type of medications that the licensee is allowed to administer. There's typically a narcotics restriction, so the nurse is not allowed to administer any kind of controlled substances. Typically, that lasts for it can be about 6 months of continuous practice within the requirements that are allowed, and then at that point, you can petition the board to maybe lift that restriction. Certain restrictions, as time goes on in the program, you have the ability to, ask the board, petition them to maybe lift them. So specific units, you can't immediately go into an ICU and work. There's no, critical care is restricted. OR, recovery room, anything like a GI lab, cath lab, um, home care, agency work. Um, all of that is not allowed. It initially, especially initially. They you 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 have to you have to practice with a supervisor present within the physical building of where you are working too. Um, Also, monthly reports are due. You have a progress report that has to be filled out every month. Medication documentation, medication prescriptions from your physician. You have to have a PCP actually that is involved in your contract, in your consent agreement, with both the PNAP and the PHMP, and that is so that any medication that you are prescribed, um, has to be uh, known by both of the monitoring bodies, um, and that includes pretty much anything. The only medications you can take without having a prescription from your physician are Tylenol, acetaminophen, ibuprofen, aspirin, and that's it, I think. If I don't think I'm missing any. I mean, I know I had to get a prescription for Pepto-Bismol as a PRN. So yeah. So but it's all an accountability thing, and not self-medicating. And then there's the financials. There is an annual fee for PNAP, and that depends on your license type. Like a nurse practitioner, a CRNA or a CRNP versus an RN or versus an LPN or even a nursing student, because nursing students are eligible, excuse me, to be in this program as well.
So we
Um,
received a question about the 90 and 90, and I know we haven't gotten into it as well, but once the 90 and 90 is done, how we have to attend 3 meetings per week. So the question was, could the 90 and 90 be in SMART recovery or other non-12-step recovery programs? And I answered that in the chat a little bit, but if we want to expand on it. So I said yes, in some cases. When I did ask my case manager about this, as far as the 3 meetings per week I was required to attend throughout my contract, I was told I could attend 1 non-12-step meeting out of that 3 per week, and that the other 2 were required to be 12-step. However, I do know other participants that were told all 3 had to be 12-step. Jen, what was your experience?
I pretty much stuck with the 12-step just because I was very not knowledgeable of the of anything really in addictions until I was in it myself. So,
Mhm.
but yeah, and that was the other thing that Rachel mentioned at case manager. You are assigned a case manager through PNAP, who is with you, that entire time, and that's pretty much your contact. So you don't have to, it's very hard to get a hold of the PHMP or the Board of Nursing. So it's, much better to go through, your case manager.
Absolutely. And PNAP gets a bad rap sometimes, right? Because there's a lot of nurses compared to a lot of other license types. But this is really overseen by the PHMP, and PNAP is just ensuring that nurses are able to make it through this program with best case scenario, that they're successful and able to retain their license to work where possible. We also received another question that we were kindly answered as well about what MOUD is. As we might be able to get into later in the presentation, Jen and I will talk about our experiences, and both of us come from an opioid use perspective. So we are a little bit biased with that talking point when it comes to FDA approved medication substance use disorders. This doesn't call out medications for alcohol use disorder, but there are none that would be restricted for that. The medications for opioid use disorder that are restricted include buprenorphine and methadone. However, that being said, there is some current stuff going on with the Department of Justice. There was a case in the state of Indiana that a licensee was stating they were being discriminated against for their use of buprenorphine, and they did win that case. So I have not touched base personally with the state board, with the PHMP, nor with PNAP to see if that is changing any of the recommendations in Pennsylvania. Also worth noting, there was a DOJ case of a Pennsylvania resident involved in drug courts that wanted to be on buprenorphine, I believe. It might have been methadone, but one of the two. And they also were winning that case as a discrimination case and ADA, because once in recovery, distanced enough from current use, an individual's substance use disorder diagnosis is considered a disability protected under ADA. So this could be changing. I do hope to see that is the case personally. I think that we should be recognizing evidence-based treatments. And, there's a lot of stigma still against those. So more to come on that, hopefully.
And I mean, that being said, I mean, as I had mentioned before, finding employment can be very difficult with the restrictions that are in place, especially if you come from a critical care background. You can't continue that once you are permitted to return to work. Typically, um, obviously you cannot return to work until you've finished with your treatment recommendations, you finish your treatment and everything, and then you again petition the board to return to work. But you cannot function as a supervisor, home care, as I said, private duty, an agency nurse, any setting that doesn't have direct supervision, with the operating room, emergency room, ICUs, CCUs. Um, a supervisor has to be physically on the premises. You are actually, when you are interviewing for employment, you are required to disclose that you are you are participating in the PHMP PNAP program, and you have to disclose that at the time of the interview. That can, that I have to say, I was lucky in that case. You'll hear about that a little bit later, but I mean, it can be rough. I mean, it can be. I have friends that have went on 30 interviews. I mean, it just kind of all depends on who you're interviewing with, and what their views are. I think it's kind of but like had mentioned before, the controlled medication restriction for 6 months. Um, and then once that 6-month period is up, and you've obviously had no issues within the program, you're being compliant. Your employer also has quarterly progress reports that they send in on your progress, and as long as those are all good, then you can write a letter and petition to have that restriction lifted. And you have to kind of explain why you're ready, what your action plans will be, if you get into a situation that you're not comfortable with. And there's requirements for the letter itself. And that
So throughout the contract, there's also random toxicology screening that is done on a regular basis. For this, the individual is selected 2 to 3 times per month. This can increase in frequency if there's a history of contract violations, a history of positive screens, or even if permission is granted later in the contract to return to high-risk environments such as intensive care nursing, emergency department, or other roles that Jen previously mentioned. The cost of this is on the participant. There is no insurance coverage for this. It is all paid out of pocket, and the cost does include not only the copayment that is collected at the time of testing for wherever the individual chooses to go. They must be appropriately approved testing sites, but also the cost of the test itself. So worth noting, throughout my time in this program, a couple facilities increased their copay fees. One significantly went from $25 or $30 the whole way up to over $60. And this is very evident of why urine toxicology is often called liquid gold. At that particular site, the copayment for a blood draw toxicology screen was actually lower than the cost of an observed urine collection. So really that shouldn't be the case. It doesn't take that much time for an individual to, as part of what they're getting paid hourly anyhow, to stand there and observe and fill out these forms. The forms are just as time consuming for blood as it is for urine. There's more supplies for blood. I think that the cost would cost more than these cups, right? So it's definitely something worth thinking about. There's also different options. Like I mentioned, it might be blood, it could be hair testing. It's also different types of urine testing. So they send this off with a split sample, meaning they have one that's run and another that's there as a backup if there's confirmatory or additional testing needed. And these different screens are run on different panels, none that are knowledgeable or to the participants' awareness. So we get told, hey, you're being selected for an option 3 today. We don't know what an option 3 is. We just know the cost of the option 3 is what, like 29 something. So then other days we get pulled for an option 6, and we don't know what an option 6 is, but we know it costs more, so we can only infer that it's likely more involved. Maybe there's more heavily tested substances, but we don't know exactly what that is. Sometimes it includes testing for non-controlled substances such as naltrexone. Something that I experienced was being on Vivitrol in my immediate recovery period and not recognizing that was something I needed to turn in a prescription for because I never got a prescription and took it to a pharmacy to get it filled. This was something I was just being administered as part of my inpatient and outpatient treatment. And so when I got a call, hey, your urine was positive, they don't tell you what for. They want you to admit what it is, just in case you may admit something else that didn't show up. And I had no idea what it could be. Luckily, I had a case manager who was able to say, like, think, was there anything that was possibly injected? And I thought, well, yeah, I'm on Vivitrol. And she said, we need a prescription for that to cover this showing you up positive. So it's definitely fascinating the things they can test for. Also worth noting, check-in starts day of at 1 o'clock in the morning. So it's impossible to plan your day the night before unless you want to stay up until 1 a.m., which is not what we want to be doing as nurses who are trying to retain their licenses by practicing safely, right? So it is something where plans had to change. You're trying to balance this with normal day-to-day responsibilities, work-life balance, perhaps those 3 meetings a week that you're trying to get in. So you never want to save up all 3 meetings until later in the week for the chance that you might get selected and not be able to fit that all in the same day. The cost of the program for an employable nurse, like Jen mentioned, that's $300 a year. Of course, I had some probation fines. There's also the tox screens that I just mentioned. I also had some criminal involvement, so I had to had some attorney costs. And what we haven't mentioned yet, I believe, is the Nurse Professional Recovery Group, or the PNAP group. Personally, I had to go to 63 different meetings. They usually start you out at weekly, stepping down to every other week, stepping down to monthly before you're stepped out, and that's 25 for each meeting. So as you can see, the cost of recovering from a substance use disorder, even as a licensed professional, does add up quite quickly. The tox screens is definitely a major cost, with both of the test itself and the copays almost reaching $6,000 over the course of 3.5 years. And the total without legal fees comes to over $8,000. So that full total with the legal fees for me was almost $20,000 over the course of the 3.5 years. And of course, fees can vary because if an individual gets more tests for the toxicology done for whatever reason, if the individual is looped into contract extensions for contract violations, or perhaps they're in a program where they have to prove 3 years of continuous recovery prior to the 3 years of monitoring, and their contract is greater than that 3.5 years, of course, those costs just accrue over time. So this is a barrier oftentimes for individuals recovering. I had a lot of privilege in my story. My husband being able to continue working, continue supporting our family, particularly during a time where I was not able to work and had to go to treatment. So there's a lot of hidden costs to these programs that individuals have to be able to overcome in order to successfully complete. So since our program completion, Jen and I both have gotten into owning our own stories. We both really enjoy talking about this, and it helps us to help others as addictions nurses through self-disclosure. And controversial, there's a lot of opposing research on it, but we have both found it helpful in certain scenarios to share our stories, whether that's in our own work or with coworkers or just through things like we're doing today. We also both enjoy advocating to reduce stigma and providing education, not only on our own journeys, but as addictions nurses who have a great repertoire of education under our belts. And something that I ended up having to do that I will get into a little bit more later is apply for expungement. I was able to get my records expunged, applied for that in April of 2019 and got them approved almost 2 years later. Thank you, COVID. Things took a lot longer.
I am still
But
waiting on
I
mine.
finished. Yeah, geez, oh man. Yeah, see, things just take a while. And I think it was, at least for me, it was surprising, especially going down a path where I was set up for expungement and still seeing it take that long. I recognize some of the barriers that individuals that I have worked with and may work with in the future have been faced with and likely are still battling. I finished PNAP and the PHMP in December of 2019. Jen, what about you?
I finished in August of 2020.
Okay, not long after. And I know something that I strived towards during my time in these programs, and since I was working as an addictions nurse, was getting certified as a certified allied addictions practitioner through the Pennsylvania Certification Board, but also as a certified addictions registered nurse through the Addictions Nursing Certification Board, which Jen also obtained. So there's only 70, I think 71 of us in Pennsylvania. So it's
Yeah, there's
definitely
not many.
something worth saying yay about as an individual too that is recovering themselves from a substance use disorder. We've both kind of found our own career pathways as well. I, like my bio mentioned, started out in direct care in an office-based addiction treatment setting, went to an inpatient setting for a brief period of time, and now work for managed care. And Jen ended up in managed care as well, but
Yeah.
also had a different pathway if you want to share on that a little bit.
Yeah. I started in a inpatient, like a non-hospital based inpatient detox and rehab facility. Initially started as the intake admission nurse because of I couldn't work in detox. I couldn't pass the controlled substances. I couldn't detox meds. So I started in intake, then became after my narcotics restriction was lifted, I continued there for a couple years, worked as a staff nurse, a charge nurse, and then eventually the nurse educator and trainer before then also uh, going into managed care, and where I'm a clinical care manager.
And something else that I've been able to accomplish since completing these programs is publishing an article on some of my experiences. I definitely highly recommend everyone, self-promotion, go and read, because for me, it took a little bit of time to take the sting out of my bitterness of this barrier to getting my life back and recognize some of the value behind it. But now I'm able to take a step back even further and look at it with an attitude of gratitude, but also a critical eye that I can say, here's where we can maybe improve some of these programs so that they're not only accessible to all, but achievable to all. So what can you do? It's very important to recognize there's no one size fits all to substance use disorder. Abstinence-based recovery is not the only way, although it is oftentimes pushed by different individuals and groups. I think it's also important that we educate people that substance use and substance use disorders are very different. They're not just one and the same in a lot of cases. Individuals can use substances recreationally without fitting that criteria for a substance use disorder. And oftentimes there are individuals who use substances in a recreational way that do get looped into these programs. One example that I remember is an individual who had cannabis that tested positive in their urine after there was a count that was off. So in where we get the medications, the counts were off. All the nurses that were on that shift got tested, and this individual had cannabis in their system. So they got looped right in, the same as individuals like myself that struggled with fentanyl use. As I mentioned before, with the substance use disorders and medications for opioid use disorder, I think it's important that we all advocate for evidence-based treatment. I go where the science goes. Sometimes that's difficult because if we find that abstinence-based recovery works for us, it's what we want for everyone else as well. We only want them to find that same joy in recovery that we've all been able to find. And it's easy to be very biased to say, hey, this worked for me. You have to do it my way. This is going to work for you too. But we have to really follow where that science is taking us and where evidence sits. I also think it's important that we recognize and address stigma and discrimination in the healthcare setting. This is getting more of a spotlight in recent years, but we have a long way to go. We are just dipping our toe in the water right now as far as stigma and discrimination as a whole. But in a smaller slice of that pie, in relation to substance use disorders. And one way that we can all start to do this today is by watching our words and utilizing non-stigmatizing language to include person-first language. And some of the examples of this include ways you hear me talking about my own recovery, that I identify as a person with a substance use disorder. In certain realms, you might hear me identify as some of the examples in the left side column, but this is really in realms that there are other people recovering, such as 12-step meetings or other recovery groups where it's empowering to own that language and it helps with acceptance. But you'll never find me utilizing this language to identify someone else. These individuals have a diagnosis. It's important to put that person first, that they are a person and not their diagnosis. I also tend to use the words substance use or substance misuse rather than abuse. These are inanimate objects. They're not people. People can be abused. Drugs are misused. Also, when referring to people or even toxicology screens, I don't use clean or dirty. These are people in recovery. They're people who are abstinent or not drinking or not using drugs, and the testing themselves are negative or positive. Also, babies. Babies can't be born addicted. The substance use disorder criteria are biopsychosocial. So just because a baby is born dependent on a substance or affected by a substance does not mean that they're born addicted. And one that I think is going to take some time to change is this medication-assisted treatment or substitution or replacement therapy. It's very deeply ingrained. We all know what MAT is when we're working in this realm, but we don't speak about medications to treat other diagnoses like this. If someone's on an antidepressant, we don't say that they're on a medication-assisted treatment. If someone is taking an oral anti-diabetic, we don't say they're on a medication-assisted treatment while they're also doing exercise and diet management and whatnot. These are medications that are part of a holistic treatment plan. So I think we need to shift that language to align with other medical diagnoses as well.
So what can you do? What if someone that you know or work with, is having trouble? What are things that you can do to help? Well, the a big thing is to recognize the red flags, but also be cognizant that it may not be substance use. I mean, it could be something else going on, but certain red flags. And I think I probably did all of these, but volunteering to work extra, pass extra medications for, pay, um, other staff members' patients, excessive time like spent in the medication room, inappropriate prescriptions, absenteeism, frequent tardiness, frequent calling off. Um, with sometimes without notification, just being unreliable in meeting any kind of deadlines or keeping appointments. Your work performance kind of can fluctuate, poor record keeping, if a lack of documentation is noticed, especially when a controlled substance is administered, that can certainly be a big red flag. Frequent disappearances, throughout the shift. Long trips to the bathroom, trips out to your car, that kind of thing. Heavy wastage of drugs. Certain eh, controlled substances, especially in my case, I my drug of choice, so to speak, was Dilaudid, IV Dilaudid, and because I gave it to every patient I had. I mean, they were ordered it. It wasn't like I just gave it to them, but no, just heavily wasting of the medication. Um, just progressive deterioration in personal appearance, hygiene, personality changes, depression, anxiety, mood swings, sometimes, compulsivity, suicidal ideations, increased isolation. I know in my case, I was always the person that was social butterfly, planning everything for for the shift, a little potluck dinners and everything, and it I definitely changed to isolating in the back of the unit and not really talking to my coworkers, wearing long sleeves in the summer, or when it's not appropriate, um, patient and staff complaints about behavioral changes and attitude changes, and then just suffering relationships with colleagues, staff, patients. um, it's there are definitely some red flags there, but like I said before, I mean, it could be something other than substance use. It's always good to keep an eye, try to recognize.
Absolutely. So, what if you do recognize this as a potential issue? What can you do? What if it's someone I know or I work with? This is really hard. I don't have a great black and white answer for this. It's important to know the policies of your organization or the jurisdiction that you're working in. If someone is comfortable, it's great to speak with that person individually, maybe outside of the work setting. So it's not bringing it up when this could potentially interfere with patient care, but it's also important to intervene to prevent a patient care issue. So this is really based on that individual's personal comfort level. If they're not comfortable talking to that person individually, it is okay to go directly to management or leadership. Or if that's not comfortable, it's okay to go directly to PNAP or the PHMP as well. Someone had put in the chat that these programs, while good because they can route people to help, are sometimes they can be seen as a deterrent as well. And that is definitely the case. And that's one of the caveats with reporting directly to PNAP or the PHMP, is that someone could get looped in with these programs that are difficult to complete and do have a lot of challenges and may not be the best fit. But this is a case-to-case thing. There's no easy answer to what should you do, because you may not be sure, but at the same time, if you don't intervene, that person gets further along in the disease process or might have a patient safety issue. If you are a manager or in leadership, I definitely say consider hiring people like us, whether we're involved in the health professional monitoring program currently or have been, if it's possible or appropriate to do so. It's difficult. Like Jen mentioned, I had in my story put in over 90 applications and had over 30 interviews, and there were some that I could tell they would have still continued with hiring me if they were able to, but they couldn't support someone with a narcotic restriction or certain workplace restrictions that I had. But there were also others that I could tell it was just stigma. And, once I let them know I was in this program, the light just left their eyes. So consider it. We can and do recover, right? If you do hire us, please ensure that all of our reports are done on time. It's okay to place the responsibility of the reminders on the employee. But if you tell them that you are going to do it that day and don't get it done, give us a heads up. A friend of mine had an issue where they did get some extra time tacked onto their contract because the individual responsible for doing the reports said they were going to and got behind and did not do them. And although that individual did not check and continually remind and hound their workplace supervisor to do that, they were trusting that this person would do it, and they didn't. So that extra time did get tacked on, and that's devastating from a cost perspective, from a recovery progress perspective. And please do make a reasonable accommodation so that we can meet requirements of our programs, whether that's attending the meetings we need to or doing this random toxicology with little notice. If an individual is working a 7 a.m. to 7 p.m. shift, it is extremely difficult to find an approved testing facility that is able to have the hours that would work for us to be able to go do these observed urine screens and other tox screens. So if your facility is able to become an approved testing site, it's super easy to do. You just need to be able to work with Recovery Track and get these forms and have people on site that are willing to do these observed screens. There's no cost. It's just they send you all the materials necessary. That can be extremely helpful. And there's a lot of hospital sites that have avoided doing this for a variety of reasons. Some of it even from, well, how are we going to do this if we can't bill for it? This is as easy as getting one of your medical assistants to say, hey, I'm cool with doing this for this person. We don't need to be charging these people. It takes 5 minutes tops. And this can help these individuals to recover.
So what if it's me? What if it's you that's in need of help? Um, I mean, you I would consider seeking treatment sooner rather than later. Um, you can always call the number on the back of your insurance card. Every county in Pennsylvania, every county has a drug and alcohol office. They can assist in treatment drug and alcohol assessments, in finding treatment, in all of that. Mutual support groups. It doesn't necessarily have to be a traditional group. It doesn't have to be a traditional 12-step group or that it they're available pretty much everywhere. I mean, you could kind of find a support group all over it. And the other thing is, I would definitely say approaching it in a holistic way is you need to. It's the entire person needs to be treated. The entire body. I mean, the physical, mental, emotional, your spiritual health. There are a lot of people that are willing to help. Friends, family. I mean, that's that that stigma is there, and it is hard to break through to that. I know for me, I knew I needed help, I knew I wanted help, and I knew I wanted to stop what I was doing, but I really had no knowledge of how to go about that. I mean, I really didn't. I mean, and calling my insurance company, I was not going to do that. That my insurance company was my employer. I mean, that I wasn't calling them. I didn't know what to do. But yeah, there really is help out there. It's 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 a hard thing. I mean, but like Rachel said, I mean, we do recover.
Mhm. So now I think we're going to get into a little bit of our personal experiences now that we've created this foundation. I am going to stop sharing the slides now so that, this isn't just a big screen that's being shared while we talk a little bit, but I just wanted to at
Rachel,
least.
would you mind if I had some questions come in privately through the chat to me. Would you mind if I asked a few of them real fast?
Absolutely, let's do it.
Okay. So one person asked 90 and 90, or well, it's more of a comment, I guess, but they said 90 and 90 when nurses work 12-hour shifts sounds unrealistic and sets nurses up for failure, job career loss if they are brave enough to ask for help. We are trying to lower barriers to treatment, right? So that's just a comment.
Yeah, and I can add on that a little bit. Oftentimes, individuals are not, during this period of time, able to be working. They, even if they have an active license, they are they agree once they sign the contract to not practice under that license until they're given permission to return from work. So usually that 90 is during that period, but that doesn't mean there aren't still barriers, because that means there's not an income. And to get to these meetings, we have to think about things that are social determinants of health, and that does include transportation. If an individual has had any involvement with driving and controlled substances or alcohol, then they may not have a license. If they live in rural areas, this is an issue. Once you're involved in a lot of recovery meetings, oftentimes people are willing to give rides, but that's hard to establish for someone who's maybe never been there and doesn't have help.
All right, thanks for expanding on that. Another question, someone wanted to know if felonies that are decades old could be an exception if a person has multiple years of recovery.
So, assuming this is likely if an individual may have that criminal background and wants to get into fields that are in these license types in healthcare, I'm assuming that's likely what
Yeah,
this is
I
asking.
believe that's what they're referring to.
So this is another toughie because I've seen multiple different things happen. I've seen individuals go through their schooling, sit for their licensing exam, and then they're honest on that application and say, yes, in the past I've had issues with intemperate use of substances, and get looped right into these programs, even though they have 10 years of recovery. It's not documented, so they get looped right in. I've had individuals where that happens and they are honest and they fight it. And in which case they've been able to, instead of get looped into a 3-year contract, it's down to 1 year. I've also had individuals that I know that did not disclose their past. Maybe they didn't have a criminal history, but they didn't disclose their past. They didn't have to do the program, and they were able to just start practicing their licensed profession. There are also cases where individuals may be in this program as a student trying to get ahead of it. Being that it's 3 years long, though, oftentimes they're not able to get ahead of it to try to complete it before sitting for their boards. Oftentimes the licensing boards want to see you practice while under monitoring for a while. There's usually not a lot of exceptions where they will just completely disregard an individual's background. However, if you can prove that you've been in treatment, right, going to different like inpatient, outpatient, individual counseling, if this is someone's own personal story and you're going to meetings and things like that, get a paper and have it be signed, and write down the name of the meeting, the date, and just get a little signature under it. All of these things can help your case to try to fight to say, hey, I shouldn't have to do this stuff. Look, I've done all these other things ahead of time. But oftentimes people are not given that heads up. They don't know to do this ahead of time. So they might end up still routed through the same pathway that we've gone down.
All right. Well, I guess I can save, there's some more, but we'll save that if there's time at the end.
Sure.
All right, thank you.
So I am going to tell you a little bit about my story. As it said in the beginning, I have been a nurse since 1996. Pretty much destined to be a nurse, I guess. My mother is a nurse. My grandmother was a nurse in the Navy during World War II. I mean, it was, my stepfather was a PA, a physician's assistant, and medicine was always in our family. And I really was a late bloomer. I would, jokingly say to addiction. I had been working for I think almost 15 years at that point, before I really had any these problems, pretty much reared their head. Um, I had been working in a hospital, it's a level 1 trauma center facility in an orthopedic, ortho-trauma, ortho-spine unit. I worked for the last 10 years. I had worked there had worked steady night shift. I was the night shift charge nurse. I was, being a nurse to me is, I mean, like I said, it was in my blood. It was a calling. It is a calling to me. And I was just, that was like my sanctuary was actually at work. I mean, I pretty much identified myself first as a nurse before even saying I'm a mother and a wife. I mean, it was that was my main identity. So, after working there, for about 15 years straight, and I, was having all this foot pain, and I knew I had like a bunion on my foot, and I really just did not want to have surgery on my foot, at all. Um, and so for about 2 years, I kind of babied it and had multiple pairs of shoes in my locker at work that I was constantly changing. Finally, I just kind of gave in and ended up seeing one of the surgeons that was a colleague, worked in the orthopedic department, and I needed to have surgery. It was going to be a simple little bunionectomy, off work for 6 weeks. Well, that turned into a lot more. Ended up a lot more complicated. I had to be off work for um, 12 weeks, completely non-weight bearing on my left leg, for 12 weeks for 3 months. And this was in the middle of summer. This is actually funny because this Friday is Friday, May 13th, Friday the 13th. My surgery was May 13th, Friday the 13th, in what 2016. So um but so this surgery ended up being a lot more complicated. I felt so horrible that I was going to be off the entire summer. Anyone, if anyone that works in a hospital or really anywhere knows, like, those vacations are set. You can, certain you can't have everybody off at the same time. So when I was, obviously going to be off for a lot longer than anticipated, I was so worried about vacations and short staffing. Um, so after my 12 weeks of non-weight bearing status, I went to my final follow-up appointment before I was going to return to work, and surgeon said, "Okay, looks good. You can start to bear some weight now." And I'm like, "Oh, great!" And then went back to work 3 days later after not walking at all on my left leg for 3 months. Went and did a 12-hour shift 3 days after. And I could still hardly walk. I couldn't even get my foot in a shoe. I had to wear like still the cast shoe and everything. So of course, this entire time, I'm still taking my prescribed pain medication. Um, it was very easy to get refills because I knew the surgeon, and it was just easy to get those refilled. And so continuously, I was on opiates for now, 3 months. I go back to work. Um, because I shouldn't have been, working a 12-hour shift on my feet and everything. Within like a month, I ended up with lymphedema to that leg, ended up having to go and have, treatment for that and everything. Long story short, I was on the verge of running out of my prescription, called the office, and they said that my surgeon, he was not there. It was a family emergency. They didn't know when he was going to be back, but the PA would see me. He wasn't going to prescribe anything without seeing me. And I'm like, okay. Well, I get to the office, and he said, it's at this point I had been 6 months post-op, maybe more, 7 months, 6 months. And he's, said, you should not still be taking this at this rate. I'm just going to he gave me an NSAID. He gave me diclofenac, Voltaren. And but so of course, I'm like scared to death, thinking, oh my gosh, I've been taking pain medicine continuously. How am I going to go to work? You know, I'm going to be in withdrawal or something. I really didn't know, but I knew that I had been taking pain medication for that long. Um, so I like I said, I had mentioned about Dilaudid before, and where I worked, all of our surgical patients were put on a Dilaudid, what's called PCA, patient-controlled analgesia, um, usually typically for the first 24 hours after surgery. And that's that little button they can push and give themselves a dose of pain medication. Um, so once that little patient-controlled medication order is finished for the patient, the nurse would discontinue that, and then the patient would be started on usually oral, pain medication with Dilaudid for breakthrough pain. So Dilaudid or hydromorphone is, at least on the unit I worked on, it was supplied in a 1 milligram like little vial or Tubex. Typically the dose is a fraction of that. It could be like 0.2 milligrams, 0.4 milligrams every 2 to 4 hours for IV for breakthrough pain. So you're wasting a large amount. It's a single use. You can't reuse it even for the same patient. You have to waste it. Well, you're working in a super busy unit and you have to have a second nurse to witness your waste. It becomes very easy to just, you know, go in to the med room and be, oh, I hear, can you waste this with me real quick? And I mean, I've done it. We've put your code in and here, waste, I need to go. My patient's crashing, down the hall. So it was very accessible. And the first time that I actually used it, I had inadvertently actually had a waste in my pocket that I had forgotten to waste. And this was shortly after running out of pain pills completely. And I got home from work in the morning. All my kids, my kids and my husband was at work, kids are at school, and I'm getting, I'm like crying. I get home from work and I'm in tears because I'm in so much pain. And I have to work again the next night, and I'm changing out of my scrubs, and I reach in my pot to empty my pockets, and there's that Dilaudid. I'm like, oh my God. And, so for 2 hours, I stared at myself in the mirror and just um, fought with myself about how am I gonna, I can't do this. And what am I like, that's crazy. I didn't, it was I guess a moral argument I was having with myself. But um one of our sons has hemophilia, so we have, which is a clotting disorder, a blood disorder. So he has to infuse IV like a factor to help clot his blood so that he doesn't bleed if he bumps his knee or something minor. So we have sterile infusion supplies at home. And after 2 hours, I did try that, and used like a tiny little bit, and of course was like, I'm never doing this again. This was the last time. Yeah, well, that was not the last time, obviously. My usage, I was shocked. Like looking back now, like it really increased. I couldn't even believe how quickly. Um, Long story short, for about 9 months, then I was using, just pretty much pocketing the wastes of Dilaudid, which can really add up if you have 4 or 5 patients and they're even if three of them are on Dilaudid in a 12-hour shift and you're giving it every 2 hours, that's a lot of waste. You're taking down PCAs that have 30 mLs of Dilaudid in it, and you're supposed to waste it. So it definitely got to be um, very easy, as I said, very accessible. Um, and at that, during that time, my usage increased from like using that tiny little fraction, point 0.2, to like a lot. I mean, I think at 1.3 milligrams, like 4 to 5 times a day, IV. I mean, I would, my ritual was I'd come home from work, I'd go in the bathroom, I would, use before I would go to bed, before I would lay down. And one time, the toward the end of it was actually several days before my intervention, I'll say, I had, you know, I had gotten home from work, did my whole ritual thing. And then next thing I knew, I woke up and it was, 1:30 in the afternoon and I'm laying on my bathroom floor. Um, so that really scared me. I knew I wanted to stop what I was doing. It was making me feel just horrible, disgusting. I was so ashamed. I felt like I had betrayed my profession. I mean, I just was it was I just felt so like just terrible. I mean, it was the shame and the guilt was awful. Um, but yet again, I did not know how to ask for help. I figured I would be, I figured I would not be a nurse. I didn't know anything about any of these, any of the programs. I had no idea. I figured I would lose my license. So of course I wasn't going to do that. The other thing, I was getting my supply of the substances that I used from work. I didn't even know how to get, like, I remember thinking, like, what if I get fired? I don't even know where you buy drugs. Like, I mean, I was so naive. I mean, it was just, it, I can kind of laugh about it now a little bit, but so I go into work one night, and my name's not on the assignment board, and it's of course 7 p.m. and I say to the daylight charge nurse, "What, am I getting pulled to another unit?" And she said, "No, I not that I know of. But our manager's in her office." And I'm thinking, why is she in her office at 7 o'clock? Oh, and then I knew. So I was just thinking to myself, I went to my locker and put my bags in my locker, and then I went to her office. And but the entire time I'm thinking, should I just leave? Like, I kind of knew what was up. And she said, "I need to talk to you. I'm just waiting for some other people to arrive, human resources and the security for the hospital." And as soon as they got there, it was, I just, all of a sudden I just felt this, like, this feeling of relief, and I just burst into tears, and I was, yeah, said, yes, I need help. I need help. And now I had worked for, my manager, I had worked on this unit for 20 years. I actually, the day that I was officially terminated, I got in the mail, "Congratulations on your 20 years of service." So, I mean, and I had worked for the same manager. She knew me. I mean, we were friends. I mean, she knew there was something going on with me, that this was not, I mean, she knew me. Um, and I do credit her for absolutely saving my life, because had she not, I don't know what would have happened. I don't want to think. I mean, I can think about what could have happened, but so at this point, I have to go. They have to take me to the emergency room to do that fitness for duty test and everything. And um, I did all that, and they, of course, would not let me drive back home. I had admitted to using substances, so I couldn't drive back home. My husband, at this point, it is midnight, and my husband, he's sound asleep, and he's very difficult to wake up. So I'm trying to call, and he's not. He had no idea. Nobody knew. I mean, nobody in my family knew. I hid it completely. I wore long sleeves. If I had to wear short sleeves, I would put makeup on my arms. I mean, it was, I did anything I could to hide that. My husband thought I was having some kind of, um, psychiatric issue or something going on. He didn't know what was going on with me. He just knew that, my moods were very erratic, and I could be very irritable, and I was sick a lot, so he thought I was depressed, or he didn't know. So I ended up, my mom answered the phone at midnight, and she came and picked me up, and, took me home. I had to leave my car at work, and she came in the house with me, and I woke up my husband, and he's like, "What's the matter?" He waking up at 12:30 at night. I'm supposed to be at work, and I'm there with my mom. Like, what's going on? And I told him, and he of course, um he both my parents, my family, my husband, they are so incredibly supportive. My husband was actually, he felt a lot of guilt. He said, that he didn't recognize what was going on, and what I mean, that I hid it. I mean, that's what I did. That was my goal, was so that nobody did know what was going on. Um, so what had happened is um, I had was going through the employee assistance program, the EAP counselor, after I was, found out at work and then suspended. Um, so they had recommended that I self-report to PNAP, that was better. And I said, okay. Meanwhile, didn't even know what PNAP was. Like I said, I had not heard about them. I didn't know anything about it. So I self-reported. Long story short, again, I ended up going completely cold turkey on my withdrawal of medication or detox of um, of my use. That was a Thursday night when I was found out at work and sent home, and so Friday, we're a blended family. That's my husband and I. We both have kids from previous marriages. We have I have two, he has three. We all live together. So our kids were not home that week, and they were with their other parent. So when I was he took care of me for while I detoxed and felt like I was gonna die, thought I was gonna die. Knew that I wasn't going to, but wanted to because I just felt so horrible. Um, I I threw everything away that I had had at home, like, as soon as I got home. Like, I didn't want I just in front of my husband and my mom, I'm like, "Get rid of this, I just didn't want to do any of that. So after, the weekend, feeling like like just death, um, Monday morning, I have to go meet with this EAP counselor, and I'm still, you know, in active withdrawal. I mean, I was so miserable. Um, but I did end up self-reporting to PNAP. I ended up going for a to be assessed for treatment. Started in an IOP, which intensive, or I'm sorry, they did not recommend inpatient treatment for me, so I started in a partial hospitalization program, basically like 4 days a week for 6 to 8 hours. I did that, then stepped down to an IOP program that was half days, outpatient, and then just the PNAP, healthcare professional meetings. But it was 15 weeks of the outpatient treatment, um, and I it everything was going really well. I was finished with my treatment. I had finished my 90 and 90. I had a sponsor. I was going to meetings, and I'm finally allowed to. I petitioned the board to be allowed to return to work, and I get the okay for that. And then I get a phone call. I let it go to voicemail, and it was an agent from the Pennsylvania Attorney General's office. And this is 8, 10 months after I'd been, in recovery for 10 months at that point. And I was just like, oh my God, and just scared to death. So I called my PNAP case manager, and she told me what to, she said, you need to call an attorney, you call this, and referred me to an attorney. Um, Rachel and I had the same attorney, so those financials that she showed, they were pretty much identical to mine. Um, so yeah, I had to put down like a $10,000 retainer for an attorney. Had to go meet with the agent from the Attorney General's office, and my attorney and I, when we got to his office and we sat at the table, and the agent put down this huge binder that was very, very thick, and opens it, and the first thing is a picture of my car in my driveway at my house. And I'm thinking, oh my God, they were doing surveillance on me. I mean, I was like freaking out, and this, like I said, this file was so thick, and the agent said, and he pats his hand on the file, and he goes, I already know everything. He goes, I want to hear your story. I want to hear your point. And I just told it all. I mean, at that point, honesty was, I wasn't going to lie about anything at that point. I figured the worst is already, not that that withdrawal that I had in the very beginning that felt like death. This couldn't be as bad as that. But of course, I'm scared to death, and I told him everything, and he said, he goes, this is only one, this this is only 30 days of your last usage on the medication, the AccuDose machine that we use to dispense medications. This is only your records for the last 30 days that you were employed. And he goes, according to this, I could officially, charge you with, it was something like, I can't even remember the number, 89 counts or something. It was really really huge number. And he said, but you've never been in trouble before. I mean, I had exemplary reports at work prior to the last you know 2 years that I worked there, last year that I worked there. He said, what we're going to do is you'll be charged initially with one felony count of possession under the Controlled Substance and Cosmetics Act. And he said, but you know, I'm going to advocate that be, you know, changed to a misdemeanor. So what happened after that is the following week I had to be processed for my charges. Well, wasn't really thinking what processed meant. I mean, I had, I mean, I didn't really, I I should have known. I guess I was maybe in denial, but um, so after meeting with the Attorney General, the following week, we all go down to the courthouse again, and yeah, I mean, I'm placed in handcuffs, and I had to spend the day in jail, be arraigned, um, and which was, you know, I was scared to death. I mean, I had never even had like a traffic ticket, a traffic violation. You know, I mean, I was scared to death. Spent 8 hours in jail. You know, was released on my own recognizance. Um, and then when I had my hearing the following week, they it my charges were lowered to a misdemeanor, and I pled. They did what's called probation without verdict. So because I was a first time offender and had no other trouble, legal issues in that sense, I basically was saying, I'll just take this probation. You know, it's you're not really being you're not having a verdict. I mean, you're not being called guilty or not guilty. It's just it's basically it's, you know, probation without verdict, which sets up the expungement process for when you're finished. So I ended up getting 2 years of county probation, non-monitored. I never even met my probation officer. And another thing I was lucky, I definitely am grateful for, is I didn't have to do additional urine, you know, tox screens. When you're on probation, you could be ordered to do that. So they took, you know, they knew I was being monitored by PNAP and the PHMP. So that was, you know, that was okay with them. So 2 years of probation. And now, because now I have charges, that set me up, and I was put into the disciplinary monitoring unit at that point. And basically, it was I had already been in PNAP at that for a year now, so they gave me credit for that year. I mean, it basically they just pretty much continued my same VRP contract, but moved it to the DMU. So now, all of my even though I am going through the expungement process right now, my probation's been finished. My charges are still, everything is still visible on under my nursing license, and will be forever. Even once my charges are expunged, they'll be on there. It's fine. I mean, what am I? It's my story. I mean, it got me to where I am. So yeah, so for March 9th, I celebrated 5 years of recovery, and I work as a care manager now for a managed care company that a behavioral health managed care organization. I have a caseload of patients from two counties in Pennsylvania. We're a Medicaid. We have a Medicaid contract, and I try to help them, you know, obtain access to services and the things that I didn't know how to do. So that's kind of, I feel like everything kind of happens for a reason in in a way, and finding that reason for me was, you know, I spent the first half of my career doing one type of nursing, but this I feel like this is what I'm supposed to be doing. I just have this great passion for helping and advocating for this. I mean, it's oh, I'm taking up too much time. I'm gonna I'm gonna hand it over to Rachel.
All right, so I'm gonna just briefly kind of go over some of the differences and similarities of our stories. Like Jen, my story is opioids. My substance use didn't start until I was about 25. So I really attribute a lot of it to I was always on the go in high school, in college, hyper involved in a lot of things. Started my first job, went straight into critical care nursing. I was getting engaged and planning a wedding and buying a house. And there was a point then that all of this busyness that was in my life kind of fell to the wayside. So I think for the first time, I had to deal with feelings that I normally could probably like put to the side or mask with the busyness in my life. So I started to get uncomfortable with this slower paced work life style. I felt empty. I was struggling with some depression, anxiety. And also worth noting, I was dealing with some bullying at work. This horizontal violence that is often talked about or even not talked about in nursing is a huge problem, particularly where I was working. There, it was not a great place to be a young nurse. There was quite the seniority on our unit. So at that point in time, I began to chase what I joke is my original drug of choice, which is achievement. I was working full time as a critical care nurse. I was going part time to grad school to become a family nurse practitioner, and I began teaching nursing part-time, and that led to absolutely no time to take care of myself. Oftentimes people ask me why that first time, and I don't have a great reason other than all of the stars kind of aligned. You know, minimal time for self-care, my mental health was deteriorating, I wasn't getting a lot of satisfaction from my current job. I could rationalize it that I was only using this waste portion. It seemed to make my patients feel good. I'm a risk taker at baseline, and I always toe that line. That can be a great thing in some cases when I use it in a positive way, and other times it gets me into trouble. So instead of asking myself, why would I do this? It was more, why not? And the first time I used it, I felt like super nurse, super wife, super friend. Oftentimes, individuals that struggle with opioid use will describe this energy feeling that they're given rather than a sedation. And that was definitely my experience. I could do what I needed to do without these uncomfortable emotions being in my way. And I was back to this high achiever that I thought that I needed to be. So as we know, with this chronic and relapsing disease, this is something where things progressed. I had been using in higher amounts to achieve the same effect. I was using in riskier scenarios, different riskier times, riskier places, riskier methods, and oftentimes even use of other substances outside my drug of choice, which was fentanyl. This changes the brain's reward pathways. And for me, my personal experience is that I didn't have a lot of physical dependence because of the way I was working certain shifts and having this like fake week off in between my 3 12-hour shifts that I'd oftentimes try to group together. But I did have a lot of psychological dependence, so much so that when I started to get ambivalent about continued use, it was impossible to will myself through not using. So this became this endless cycle of just one more time. This is going to be the last time. This is it. Okay, that was it. That's the last time. I'm done. And then it just kept going. I even bought myself a bracelet that said be brave on it. It had a green triangle for mental health awareness, and it didn't matter. I thought I would be able to look down at it and willpower my way through it, but that just was not the case. I was becoming someone I didn't like. I'm stealing and diversion of these substances and supplies for my use and lying and manipulating. I had marks and bruises on my arms and on my legs that I was making excuses about. And you know, the only thing that made that go away, all of this guilt, this shame that I was carrying, was continued substance use that made those emotions blunted. I also note how, because this is a family disorder, that my relationship with my husband definitely deteriorated because I had this physical evidence of my use on my arms and my legs. And so I didn't want to be intimate with him. I felt the need to hide this physical evidence of my use. So that was an additional damper on our relationship. There was a lot of signs in retrospect that I was struggling with substance use, but because of my past as someone who was high achieving and went above and beyond, they could be explained away to other things, especially because any amount of me not being myself could just be, oh, well, she's working 2 jobs and she's going to school. Like, that's a lot on her plate. She might just be not getting as much rest, right? So my story does, my story from substance use and entering recovery does have a tipping point that includes an overdose for me. I did overdose at work on a night shift. I was down in a bathroom for about 2 hours before I was found. I was administered naloxone or Narcan, which saved my life. So I am a big advocate for that, because if it weren't for that, I wouldn't have been given this second chance at life to do what I've done in my almost now 6 years of recovery. I wouldn't have had my beautiful baby boy that I had 6 months ago, who has just given me this entirely new purpose in life. You know, it was quite the journey. Of course, I did lose my job. I was still ambivalent about recovery at that point, and found PNAP and the PHMP on Google. Called and left a message, turned myself in because I figured that if I turned myself in, that would look better. I followed a very similar path to Jen, with the exception that I did end up being recommended for inpatient rehab. And this was the part of acceptance, or the beginning of acceptance for me. And then I did follow that same pathway of partial and intensive outpatient. Same thing with the Attorney General calling me. Same lawyer. Worth noting, because we worked in different counties and resided in different counties, despite having very similar stories, we have very different outcomes. Being that I was able to enter into the voluntary recovery program. So if I had wanted to, this could be a totally private and hidden in the shadows part of my life. But for me, it was really important to own my narrative and take that and use it as something that can empower me. However, I did, when my charges got filed, make the front page of my local newspaper. So that did, in a way, take a lot of anonymity away from me. And I decided to really just own my own story after that, because, you know, despite it not being tied to my license, it is Googleable. So, you know, this is really important for me to take this platform and decide that I'm not going to live in the shadows. It's okay for those that do. That is a very personal and intimate decision. But for me, I want to take this and use all of the privilege that I am granted as a decently well-off middle-class white woman here, that you know, I can talk about this stuff and try to advocate for others that are in positions where they're presented with a lot more barriers. So being that we have just a couple minutes left, Marla was kind enough to send me some of the questions that we had. Someone had asked, because they had to step away, what contributed to the beginning of substance use with Jen. And Jen, that, correct me if I'm wrong, but that was a lot of your foot surgery and pain that you were dealing with that, and then some over prescribing and the length of prescribing that went along with that.
Correct. That was it.
Someone had asked, what role does privilege play in these kind of programs, and how would a person of color likely be treated in this situation? This is multifactorial. I think as far as the nursing board goes, there would not likely be a lot of differences. However, because the nursing board and other licensing boards are going to be utilizing recovery pathways that include treatment assessments and things like that, there could definitely be a lot of discrimination and different factors in those pathways that is deeply ingrained in systemic racism. Jen, do you have anything to add on that?
No, I agree completely. Yeah.
Someone asked, do hospital systems see that offering recovery solutions to their nursing staff and other healthcare professionals, along with their beneficiaries, as a way of keeping staff and better retention and a way of decreasing time calling in sick? My experience is a lot of nurse leaders don't even know about these programs either, or unless they've had people in them already. I know that, a lot of places have employee assistance programs, but even that is oftentimes not best utilized as best they can. It's great to see that that's part of Jen's story because of how important it is. Jen, do you have anything to add with that one?
No, I mean, definitely, I think the employee assistance, that counselor was incredibly helpful to me. So I do try to advocate and try to tell, people that take advantage of that. Take advantage of your EAP counselor. They can be a very, very good resource for sure.
So we are at time. I'll let Marla jump back in here, but I did put our emails in the chat. Please feel free to reach out to us. We could talk on this forever. It's very near and dear to both of us. And also we have a private Facebook group if you're someone who's struggling with substances currently or are a person in recovery, wherever you're at in your journey, feel free to join us. It's supposed to be a safe place that are just for people like us. So please don't join if you are not a person struggling with substances or in recovery as a healthcare professional. But otherwise, please join us. We're there. We're able to help. Reach out to us. And Marla, I'll let you take it from here.
All right. Thanks so much, Jennifer and Rachel. That was really great. I learned a lot about PNAP that I didn't know. So thanks everyone else for your great questions and for attending today's webinar. We would like to remind all participants that a copy of today's PowerPoint, along with the recording of today's presentation, will be uploaded to the webinar library located on IRETA's website sometime within the coming week. Once we have these resources posted, a link will be sent to all of today's webinar registrants. I now want to remind you of our evaluation and CEU process. You will receive several follow-up emails from us. The first email will include a link to the evaluation, and the second email will include a step-by-step instructions on how to obtain your CEUs and certificate of completion. Please note that it will take up to 48 hours for your CEUs to become available because we have to cross-check your attendance records. We would like to specially request that you fill out our evaluation. It should take no more than 2 minutes of your time. I also want to announce that we're doing a monthly Twitter chat for substance use disorder clinicians. So any kind of professional in the healthcare field that deals with substance use disorder will be having that on May 24th. The hashtag is #SUD clinician chat. If you would like to participate, just follow us on Twitter. And again, we want to thank everyone for taking time out of your day today to participate. If you have any questions at all, please email us. That email address is info@ireta.org. And with that, we will be concluding the webinar. Thank you so much and have a wonderful day. Thanks again, Rachel and Jennifer. Bye.
Thank you. Bye-bye.